Well, some people online have questions. Okay. Are you privy, I don't know if this is for Carolyn or Rebecca, but whoever wants to answer. Are you privy to say the name or names of the pilot medical home model currently in operation? And do you have any preliminary numbers of success or operations? So, medical home question.
So I think when I brought up the patient-centered medical home piece, it was just an example of what something might be in the market. There are, like you said, Carolyn, there are 2 pilots in the market right now. I don't know if they've been in the market long enough to actually get data on whether or not they are bending the cost curve. I'm sure if you spoke to CareFirst, they would say that it is. So that was just an example from my perspective.
And I don't have the numbers at my fingertips, but if you go to the Maryland Healthcare Commission website, there is a special link to the patient-centered medical home all-payer pilot, which is the state pilot. And then CareFirst, I'm sure, has information on its website. There are, again, I don't have the numbers, but there are a lot of physician practices participating in both the state pilot and the CareFirst pilot.
Thank you. And let me just say, from the perspective of our Healthcare for All Coalition, patient-centered medical homes is a very important way to make healthcare more affordable. And the legislation, which we've talked about earlier, which allows the exchange to conduct active purchasing to really encourage ways to make healthcare affordable, specifically references patient-centered medical homes and value-based insurance as policies that they can pursue, and we hope they do. So thank you very much. Next question from online. Has there been a definitive decision on what will happen to an individual in Maryland if they are not insured, i.e. penalties? I assume they're referring to what the penalties are for not getting the required insurance under the ACA.
And that's defined by the Affordable Care Act,
Right.
Not necessarily by us. I think in the first year it's $95. I think it ramps up to $695 after year 3.
Right, and those are, as Becca said, defined in the National Affordable Care Act. And there has been some people who've criticized it as people aren't going to do it, they're too low. But Massachusetts' experience shows that these kind of penalties work. The penalties in Massachusetts are very similar to those under the Affordable Care Act, and the vast majority of people have gotten the insurance, and very, very few people have paid the penalties. Anything else on that? Or? Okay. One other question. Why did the ACA, the Affordable Care Act, reduce healthcare flexible savings account maximums from $5,000 to $2,500? I have no idea.
I do not know.
Sorry, I don't know the answer to that question. Any other questions here? Yes. Wait, here's a mic from Mayana. Tell us your name.
Carlo Perico, I'm over at the School of Medicine. I came in a little late, so I apologize if I missed this, but to what extent will employees of medium and large employers, if the employer chooses to pay the employer mandate, and will their employees then have access to the exchange? And have you kind of talked to medium and large-sized businesses and gotten a feel for if anyone is planning on paying the, I believe it's a $2,000 per employee penalty, and then having
Over
their
30,
employers,
right.
their employees come onto the exchange?
Right, so the penalty, I hope I don't make this up, but the penalty is $2,000 per employee over 30 employees.
I think it's 50.
The group size over 50, but over 30, so your first 30 employees are free, essentially, if you drop coverage. Yes, they are eligible to come in, individuals are eligible to come into the exchange and get subsidies. So the only way an individual, if they're offered employer-sponsored coverage, they can't get subsidies in the exchange, even in the small group or large group market. If the group does drop coverage, then they can come get into the exchange and they can get subsidies. Anecdotally, we have been talking to large groups and to consultants, and there are definitely pay-or-play models out there for those groups to try and determine what they want to do. But there's still a paternal-maternal feeling for large groups, and there's still a reason to offer coverage. It's a nice benefit to be able to offer, and so at least in the first year, our model doesn't assume that there are going to be a lot of large groups dropping coverage.
Thank you, Becca. Very good. Kevin?
I don't think I need the mic unless you need it for online purposes. questions. I have a question for Becca, maybe for Carolyn as well.
I think we do for online purposes.
Okay.
You need to get up. Kevin, it's up here.
Right here, right here, Kevin.
We're making you work.
Yeah.
Right, no, correct.
You are loud, Kevin, but not that loud.
Hi, thank you. I have a question for Becca and maybe for Carolyn as well. One of the other large things that happens in 2014 is, as everyone knows, in addition to the exchange operating, is Medicaid expansion. And so I'm wondering if you could talk about, I know Maryland's paying a lot of attention to the relationship between Medicaid and the exchange, and particularly those who might be eligible for one or the other or both at different times over the course of the year. Just wondering if you could talk a little bit about what has been done so far to address that.
Sure, absolutely. So Sarah Rosenbaum, I think, estimates or did a study and estimates that people will churn, which is really the movement between the exchange and Medicaid 4 times a year for those people between under 200%. So we very much are taking a look at that. There is a continuity of care advisory committee. We are required statutorily to have a study to the General Assembly on what we're going to do to address that. That advisory committee right now is taking a look specifically at what, when I think of continuity of care, it can be this big, right? You can talk about continuity of, where do I pay my bill, sort of continuity stuff. But this is specifically focused on if somebody's in the middle of a treatment plan, how do we make sure that they don't have to, get a new pre-auth or anything like that, and that the new carrier is responsible for supporting the treatment plan that they're already in. So what we're doing is we're taking a look at not only what Medicaid does across the country today and in the state, what the commercial carriers do today and in this and in the country. NCQA already has some standards that are already in place, and the committee is trying to pare down some specific things that the exchange should be looking at. We're doing this in concert with Medicaid and the Maryland Insurance Administration, so that the ultimate goal is to have legislation in 2013 so that that whatever we put in place isn't just exchange specific, that it's across the entire market so that you don't have any risk issues.
Thank you. Let me just say on the Medicaid point, as you all probably know, the Supreme Court, when it upheld the Affordable Care Act, did say, unfortunately, that states are not going to be required to do the Medicaid expansion, and states are deciding whether or not to do it. And I have a lot of colleagues in other states who are very upset that their governors or General Assembly are saying we're not going to do this. I think we can say clearly in Maryland that Governor O'Malley and Maryland will do the Medicaid expansion, which is a key part of it. Isn't that right, Carolyn? Yeah. Right. Question?
Okay. Hi, my name is Jelani. I'm a student in the School of Public Health, and I don't know that much about the business side of things, but there's a lot of talk from conservatives that you can't really force businesses that have over 50 employees to pay for health insurance because they might choose not to hire new people. I wanted to know if there's anything in the law that protects businesses from that so they won't be forced to make cuts. I don't know if it makes a lot of sense, but that's the argument that's given for businesses.
Right, so this goes back to the penalty. So businesses under 50 are not required to offer insurance, but there is a penalty for businesses over 50 employees to offer insurance. If they don't offer insurance, they do have to pay $2,000 per individual over 30 people, so from 31 to whatever their number is. Again, I would say that's where the pay-or-play model comes in about whether or not. Now, interestingly, 89% of businesses between 50 and 150 offer health insurance today. So I can't imagine that there are going to be too many businesses that are in that situation.
And let me just say, from our perspective, we have always believed in the fair share theory, that businesses that are large, that can afford health care, need to do so, because if they're not chipping in, their employees go to the hospital, we all pay, it increases our insurance premium. So we've always believed that large employers need to do their fair share, and the Affordable Care Act requires that. Yes?
Not allowed.
Hello.
Hello. We heard about you.
You should know this answer.
I should. This is just a general body question. With the employer versus employee choice diagram that you displayed, are employers only relegated, or employees only relegated to choose from the plan that the employers decide from? And what are their options if an employee chooses to purchase a platinum or a gold plan when the employer only offers silver plans?
So that was actually a lot of discussion last year about how wide was the employee choice going to be. There were some options that we could take it even further and allow the carrier to just give $200 or whatever the number is, and they could pick anything they wanted on the exchange. But because of the risk, right? So as you as an individual are going to know whether or not you can anticipate what you think your health needs are going to be in the following year. So to mitigate the risk factor from allowing somebody from 1 year to say, hey, I just need the bronze plan, and then next year, for example, maybe I say, hey, I think I'm going to get pregnant. I'm going to go and purchase the platinum plan. That would cause a lot of problems in the market. So the decision was to just allow the carrier to choose that one metal level and for the individual to be able to choose any carrier on that metal level. We will take a look at it in the coming years and assess it and try and figure out whether or not we can open it up further than that. But more than they have today, where the employer chooses the carrier, and if they're lucky they get 2 or 3 plans to choose from. A lot of times it's just one single plan to choose from, so it does open up at least more employee choice than they have today.
Becca, before we go on, could you describe a little bit of what the metal plans mean?
Sure.
What that means for you?
Sure. So the metal levels, as you saw up there, they are metal levels because they're called platinum, gold, silver, and bronze. They are the actuarial value. So a platinum plan, any plan at the platinum level, the actuarial value of it, or the estimated costs to the individual compared to the average cost of the plan. I don't think I'm really saying that right, but it's hard to explain. But your average out-of-pocket costs, the platinum plan will cover 90% of your costs. The gold plan should cover 80%, the silver plan should cover 70%, and the bronze plan should cover 60%. So, the average person spending $1,000 will pay the plan will pay $900, and the individual will pay $100 plus your premium in the platinum plan.
That's a very good explanation. Thank you. Yes, sir.
My name is Lee, and I'm a student at the School of Public Health. So granted that right now we're just looking at how to implement things, but in the long run, what do you see as the changing roles and responsibilities of the exchange itself once access has been significantly expanded?
Haven't gotten that far. So a couple things will probably change. First and foremost, the Maryland Health Insurance Plan members, today there are 20,000 members who are covered under the Maryland Health Insurance Plan, which is the high-risk pool, is going to go away. So those individuals are going to roll into the exchange. But there are several pieces that MHIP runs today that there's a senior prescription drug assistance program that the exchange might possibly take over. But on top of that, one of the things that the exchange has to do is run a reinsurance program for the state. So we will definitely take that piece on as well. I don't anticipate any major changes in the long run where we won't, begin to become an insurance plan or anything like that. I think ultimately it's going back to what Vinny said, which is how do we start to work with the carriers? And so on an ongoing basis, we'll be trying to modify the way that care is delivered within the state. Once especially we expand the small group market to 100 and we really gain more people in the exchange, we'll have that ability to start driving some of the change in the market. So instead of just being up and running, it will be that force behind some working with the carriers to change things.
The only thing I would add to that is that the other piece that some people thought was important when we were having the initial, sort of controversy and ultimately decision about what kind of body it would be, there's a requirement that a study be done in a couple of years to determine whether or not it would now be better to kind of morph it into a nonprofit or remain a public corporation.
Great. Thank you both.
I have a few more questions from our online audience. This person is saying, in the last two presidential debates, Governor Romney has mentioned that if elected, his intent is to repeal the Patient Protection Affordable Care Act, or however much of it hasn't already been implemented. If he is elected this November, how will Maryland respond?
That's yours, Carolyn.
Well, I think unlike the Supreme Court decision, where there could have been an immediate and definitive effect on how and whether states could go forward, I think if Romney wins the election, his promise to, quote, repeal it on day one is just a fallacy. And I'll let it go at that. So if he then makes more meaningful moves as time goes on to try to take away parts of it, we will do what we've done from the beginning, which is to say, we obviously have a huge amount of political leadership and public support for the Affordable Care Act here in Maryland and the implementation efforts. So we will gather together with our partners in the General Assembly and all of our stakeholders and sort of look at what he's doing and look at the effect of it on what we're doing and figure out the best way to move forward.
But let me just add, Ayanna, that as I said earlier, before the Affordable Care Act took effect, Maryland was already making tremendous progress. And we had expanded healthcare to 300,000 people, allow young people up to age 25 to stay in their parents' healthcare, and did much else. And we were looking at proposals like what's in the Affordable Care Act. So if that happens and the Federal Affordable Care Act is gone, which, like Carolyn, I don't think is going to happen, but if that happens, we're going to all work hard in Maryland to make sure the progress continues.
Okay, I believe this one is for Rebecca. Where can we find the descriptions for those 8 new positions and how we can go about applying?
So they are on our website. There is a link off the front page to link to the actual further on the pages. The positions that we have posted, we have a Deputy Director of Operations, we have a Deputy Director of IT, we have a PR Manager, we have a Special Assistant, a Compliance Manager, an HR Manager, and somebody that I'm forgetting. 1 or 2 people I'm forgetting, but those are the positions. So.
Okay, great. What are the minimum requirements of an employer to avoid the penalty? What if they offer insurance but make employees pay a higher percentage of the cost?
That's a good question. So the coverage for the employee must be less than 9.5% of their income for it to be considered ESI, or employer-sponsored coverage.
Okay, and this is the last one I have online. Well, there are 2. What were the controversial issues in setting up the exchange, and were there compromises made regarding control over the carriers?
I'll talk about 2012 and then turn it over to you guys to talk about 2011. So in 2012, the only one real piece of, I think that was, and it wasn't even really controversy, but pushback that we got was to move to the active purchasing model in 2016. And thanks to Vinny and others, we were allowed to actually keep it in the bill. I think that's the big one. I think from a carrier perspective, there is a requirement in the legislation that a carrier that offers outside the exchange, once they hit a certain threshold from a premium revenue, they have an obligation to also offer coverage inside the exchange. And actually, through Carolyn's process of really being very transparent and very collaborative, that actually did not end up being something, although I anticipated that it might be something that was controversial, it was not because of the process that we used.
In terms of the first year, I've alluded to probably the biggest one was whether or not it would be a public corporation, a state entity, or whether it would be a nonprofit. We also had, change is hard, and there was one group whose livelihood, they viewed themselves as sort of the most vulnerable in terms of what it would do to their livelihood, and those were the insurance brokers. And so, again, I credit the process that we we took pains to set up, and then we're really benefited from people participating in, whereby we kind of gathered everybody together and worked very hard to fashion a framework and governance structure for the exchange that kept everybody in the tent. And I think we were able to reassure the brokers with the reality of the fact, as Secretary Sharfstein used to put it in the legislative, arena when we were sort of hammering all this out. If we sort of, plopped down from Mars and were told we had to, enroll 1,000 people a day or whatever it is in insurance, and we were told that there was a group of people out there who were really good at this and had been doing it for a very long time, why wouldn't we enlist their help? And so that was sort of the principle on which we moved forward. And so the only other controversy that I remember being a sticking point was the board, and I think this was important because different states are struggling with this still even, in sort of what kinds of folks do you want on the board of the Health Benefit Exchange. And we took the view that we didn't want direct conflicts of interest. We thought the integrity of the board was really important, so we didn't want actual carriers on the board or actual brokers or folks who had a real, sort of would be in a transactional relationship with the exchange, but we wanted the expertise that we needed to really make it successful. So we have some terrific consumer advocates and some terrific folks with real experience in healthcare financing and healthcare, and we put those requirements in the law so that will carry forward as the board, over time changes.
I want to repeat Becca's wonderful story earlier about seeing the hospital, consumer, and broker people together and discussing, going back and forth, and coming to agreement. That's not easy, and I think Carolyn and Becca deserve a lot of credit for making that happen over the last couple of years.
Hi, my name's Liz, and I work at the Baltimore City Health Department. I had a question about the one single entry point for Medicaid. So my understanding is that people will have to use the exchange to enroll, go through the eligibility requirements and enroll in Medicaid. And I just want to confirm that, and also ask, when you say that the exchange will eventually in phase 3 become the single entry point for all sort of assistance programs, including SNAP, when do you anticipate that happening?
So I should clarify, yes, but with a caveat. So the exchange itself, so the system, the enrollment and eligibility system, which we call the HICS, underlying the entry point, will be the single entry point. So it's replacing CARES today. So yes, it will be the only place that people can enter for Medicaid. And phase 2 and phase 3 we expect to be done by the end of 2015. And phase 2 is the non-MAGI, so long-term care, and then phase 3 are the social services.
That's great. Any other questions? Anything else online, Diana?
Nothing else online.
Okay. Thank you very much, Carolyn, Becca.
Thank you all for joining us for the October Grand Rounds. Tune in next month. Our topic will be distracted driving, so that should be pretty interesting, and enjoy the rest of your day.
Thank you, Ayana.
Thank you.